Prostate cancer, which is what we use the digital rectal exam and the PSA for, we need to inquire as to what our patient's treatment choices are going to be. A patient that's in their 90s may very simply decide not to have these exams, because at that point, what is it going to change about the way they're going to treat their disease if it is discovered that they've got prostate cancer? So starting at 50, these conversations need to be start being held between the physician and the doctor to decide if PSA and digital rectal exam are the right testing for them. However, there are a couple segments of the population that we need to screen earlier. That's going to be our African American men, and also anyone that has a father or a brother who had prostate cancer before age 65. These are the ones that we need to start trying to encourage to be screened at age 45. Guys, don't get hung up on this testing schedule. This is all found over at the American Cancer Society's website. As far as preventative scheduling, that kind of stuff, you can refer back to it. Know that these guidelines are out there, and kind of understand what each one of these tests is used for. There's also a cancer risk evaluation tool that's out there now, and this asks clients more about family history. It just basically gives us a good idea of how to look at this person in a more global perspective and see what other risk factors beyond these direct exam measures that can be taken to determine if these patients are at risk. One of the things that you should do is know the CAUTION acronym. This is going to be very beneficial in working with the oncology client. Things that we want to be looking for are changes in that bowel and bladder. Used to, if my patient had a bowel movement every 3 or 4 days, and now they're reporting that they're chronically constipated, or they're having chronic diarrhea, there's something wrong there. Bladder, are we having changes in our frequency, the changes in the color of the output on both bowel and bladder, are something that we need to be aware of. We also need to be aware of a lesion that doesn't heal. That would be an indicator that there's something wrong there. We may need to have further exam. Unusual bleeding or discharge. Clearly, if anything is bleeding or discharging, I need to see somebody about it. So we need to encourage them to watch for that as well. A thickening or a lump in the breast or anywhere else, especially like in the axillary area under armpit there, we need to see if those lymph nodes are inflamed, or if we're getting any types of thickening or lumps there. These are kinds of things that we need to be aware of. Again, anywhere on the body, we need to remind our patients that we need to be watching for those. Indigestion or difficulty swallowing. Remember our patients with GERD, where they're constantly refluxing that acid gastric content back up onto those epithelial cells. Those cells weren't designed for that type of exposure, so these patients can be at risk for certain types of cancers because of that. Any difficulty in swallowing would again tell us that something has possibly changed, that further exam is needed. Obvious changes to a wart or a mole, we're going to be watching for those as well. Nagging cough or persistent hoarseness, another big indicator, especially with our lung cancer patients. Just so that you have a background on tumor behavior, a benign tumor, one that's not necessarily going to cause our patient any problem, one that's not cancerous. Typically it's well differentiated. We'll talk about that in a little more detail later. It'll be slower growing. It's usually encapsulated, meaning it pretty much keeps to itself. It's usually localized to the tissue of origin, and there's usually no mutation. And when you think about a benign tumor, think about the turtle. It doesn't really move that quickly. Malignant tumors, however, are quite a bit different. They're poorly differentiated with rapid growth. So we think about the little rabbit and how quickly he runs and how quickly cancer grows. They'll have infiltration or metastasis, so cancer that originally started off as breast cancer now migrates, and we start to see the patient having growths on their lungs. Remember, one of the big things about cancerous growths, they always belong and they're always named to their tissue of origin. So if a patient started off with prostate cancer and it's metastasized to the brain, when they look at those cells under microscopic examination, they would still have some resemblance of that prostate cell. Likewise with breast cancer that spreads to the lungs, the material, the growth there is going to somewhat resemble the breast cancer cell. So whenever we talk about a patient that has breast cancer and it's in their lungs, it's still breast cancer. It's just metastasized to the lungs. Malignant cancers, typically the outcome, the ending, if you will, is going to be death if they don't do some type of treatment. Left unchecked, growth can definitely cause our patients problems. Malignant tumors typically are not encapsulated, meaning they spread easily outside of their tissue of origin into other areas, and they're not always easy to remove, especially once they've spread into many different areas of the body. A couple of different images there on your screen. You see the killer T cells in that second picture. They're little white fuzzy balls, and they're trying to attack this malignant growth and kill it. So the body's immune system has seen the offender, the invader, if you will, and they're trying to get rid of it. However, their success is probably very marginal at best with a malignant rapid-growing cancer. That last image down there, the T cells, the killer T cells, represented by the little green tic-tac looking things. Again, they're trying to attack this malignant growth, and you see how it's got these feeders coming off of it going to other areas. One of the main reasons that these types of growths do this is it increases their blood supply if they increase their area. But keep in mind, these types of growth can switch to an anaerobic process where they don't need blood oxygen necessarily to survive. They'll go to an aerobic growth cycle. When we think of cancer, in order to keep some of our most common problems together, if you use the acronym CANCER, it'll give you kind of a basis to start from. Most of these patients, we have issues with comfort, be it pain or what have you. So we want to look at ways